we'd like to thank you for joining the meeting here and viewing this recording. Today we're going to be talking about what a BPCI-A Episode Initiator needs to know regarding the patient-driven groupings model for home health. As you know, this is a new payment system that went live on January 1st. And in this presentation, we're going to be giving you an overview of the model and also talking about specifically what you need to know, and we'll be providing some strategies of how we are proceeding with this payment model. My name is Shawn Matheson. Just by way of short background, I've been in healthcare about 21 years, almost as much as the value-based program for BPCI-A since 2015. I was actually the third employee with Fusion 5, but I've been a licensed nursing home administrator for that duration. For the last number of years, as I mentioned, working in value-based care, I also did a lot of primary care management for 9 years. But it's a real privilege today to be joined by Bill Dombi. Bill, we'll turn the time over to you for your introduction and the BPCI-A overview.
Well, thank you, Shawn. I am Bill Dombi. I'm the president of the National Association for Home Care and Hospice. NAC, as it is known for short, is the national trade association that represents home health agencies and hospice providers of care. Our membership is made up of all types and sizes of home health agencies and hospices, for-profit, not-for-profit, institution-based, very, very large public companies and small operations. Our membership is nationwide. We've been in existence since 1982. My background began actually a little earlier than Shawn. This is my 42nd year of doing something relative to healthcare services. I started work on that during law school time. And so thank you, Shawn, for putting up an older picture of me. I no longer look like that. I am a little bit aged comparatively, but thank you for reminding me of a time past. So let's get right into it in terms of the new payment model for home health services. It was finalized in the fashion that's now applicable in 2020. This new model started January 1st, 2020. It does overlap with the pre-existing model for patients that were on service prior to January 1st. But by the time we get to the end of February, all of the patients served under Medicare by home health agencies will be under the new payment model. And as Shawn indicated, it's known as the patient-driven groupings model, or PDGM for short. CMS, really graced all of our homes, those of us in home health care, on Halloween Eve this past October in issuing the final rule for 2020. A link to that is on this slide. Should you choose to have some free time that you'd like to spend reading the Federal Register to learn more about this, this is where you go. Just click that link. The rule contains all the detail on the new payment model, but also reflects the model that overlaps that, addresses the rural add-on, and touches on a number of other points that we won't be discussing today, that being a demonstration program on value-based purchasing, some refinement on quality measures, and a restatement of a home infusion therapy benefit that begins in 2021, and a couple of other burden reduction aspects on allowing therapy assistants to provide maintenance therapy services, a glitch in an old rule. The origins of all this action really focus in on the Bipartisan Budget Act of 2018. There was a predecessor consideration for purposes of payment model reform called the Home Health Groupings Model that CMS introduced in 2017. Congress didn't like it any more than the home health community, and so Congress stepped in and provided some assistance to the creation of these reforms with the Bipartisan Budget Act. It mandates that the payment reform begin 2020. That's in contrast to CMS's original intent of 2019. A big protection put into the legislation is that the new model is required to be budget neutral. That doesn't mean rate neutral or that each individual home health agency will receive the same amount of Medicare revenue that they would have under the old model. It means in the aggregate nationally. And what the new models do is to redistribute payments, and we'll talk some more about that in a little bit. But the budget neutral transition requirement is very important to try to achieve some stability, as this new model really is the biggest change for home health agencies since the year 2000. I mean, 2 decades ago, when it moved into prospective payment for the first time, that was a very transformational aspect of delivering home health services. This may not have the same level of impact, but it is no doubt the biggest change since the year 2000. Congress also put some guardrails around what's known as a behavioral adjustment. A behavioral adjustment is a forecast-based approach to what might be expected from home health agencies regarding everything from the utilization of services to the coding of diagnoses that affect the level of payment. All sectors of the Medicare program, when they go through some sort of a payment model change, have shown changes in behavior, be it physicians, nursing homes, hospitals. For those of you familiar with the beginnings of the DRG system in hospitals, you'll remember that there were just tremendous behavioral changes within the hospitals in terms of what patients were admitted, lengths of stay, coding of patients, and that's been mirrored in all the other sectors, including home health when changed there. But Congress said we need some guardrails regarding any kind of forecasting, because the Medicare program, in moving towards the PDGM model, was charged with the responsibility of coming up with an assessment of what is anticipated behavioral changes so that it could control spending so that it doesn't go beyond budget neutral. The Bipartisan Budget Act also required CMS to bring stakeholders into the development, which CMS did do, but 2 big changes in the architecture of the payment model were part of what the mandate was as well. The first one changed the essential feature of the 20-year payment model by prohibiting the therapy volume threshold for being used as a payment amount determinant. In the preceding model, the prospective payment system actually had big bumps in payment at certain volume of therapy visits on a patient's episode of care, so that at 14 visits over the 60 days, the home health agencies would receive a big bump in payment, and at 20 visits, they get another big bump in payment. And so concerns have long been there that those payment determinants based on volume of services incentivize the home health agencies to find a way to have higher volume of therapy visits. And Congress moved away from that. CMS wanted to move away from that. And in reality, the home health agencies did too. As much as it might have been a profitable element for some home health agencies, it was also a lightning rod for attention, leading to congressional investigations, a whole variety of audits, and also False Claims Act whistleblower lawsuits. So that was going to be probably the biggest change in the architecture of the system that we'll be talking about. And the second change that's a huge change is moving from a payment unit over 60 days to a payment unit over 30 days. And this is unique to most of the reimbursement models in the Medicare program, to have that kind of episodic reimbursement to begin with. One thing to note is that while the payment unit has moved to 30 days, there still is a 60-day plan of care and a 60-day physician certification of eligibility for the benefit. So only the payment unit component changes. But that change to a 30-day payment unit from a business perspective of the home health agencies does raise a lot of issues concerning cash flow and also may create an opportunity for some behavioral change as well. We have seen, the 27% of all 60-day episodes of care were concluded in 30 days or less. And in doing so, the question is out there whether the 30-day unit type patient will now move into 2 30 days, because front-loaded care will shift to something which is spread out for reimbursement purposes. So the home health care community is absolutely focused on that. Congress did grace us in Bipartisan Budget Act with an inflation update of 1.15. All of that base architecture that just talked about, we're going to be talking about in much greater detail as we move forward with the slides.
Bill, may I ask you two questions on this slide? One on the behavioral adjustment guardrails. Is that more referring to the procedures and such that the home health agencies have had to this point, and that not shifting in great amounts given the new guidelines? Or could you also comment on, when I read the word behavioral, and as I've studied this, it tends to infer, perhaps a behavioral care plan of a patient. I wonder if you could contrast those two.
Yeah. Let's start with that. Let's start with that later question. This has nothing to do with behavioral care to patients, patients who have behavioral care needs. This is the business and clinical and financial behavior within a home health agency. And an example of a behavioral change that's referenced here would be where the home health agency has the opportunity to choose one ICD-10 diagnosis over another, and the one that they might choose provides higher reimbursement. And so the behavioral change that Medicare was looking at was whether there was, in what degree there would be of that kind of change to upcode the diagnosis for the patient, the primary diagnosis for the patient. So that's what's meant by behavior as one example. A second example, there is an adjustment that we'll mention called the LUPA, the low utilization payment adjustment. And it varies from a threshold of 2 to 6 visits over a 30-day period. So Medicare was looking at the potential that home health agencies would seek to add a visit or two to get over the threshold, because the difference financially could be significant in terms of per visit reimbursement versus a full 30-day episode of payment. So we're really looking at the behavior of the home health agency relative to the payment model, nothing to do with the behavior of the patients or the physicians or anybody else.
Well, thank you for that clarification. I know when I first was studying this rule, that caught my mind as, does this modify the home health or the patient care plan needs? So thank you for that clarification. Second quick question on this slide, the 30-day payment unit you mentioned. Our partners, especially those who are engaged in orthopedics, really like the front loading of the visits for therapy. With this new model having the 2 30-day payment units, do you anticipate the desire for home health agencies to spread those visits out longer, i.e. not front load as much?
I don't think we can really generalize there. I mean, we, have had many conversations with our members, and we've did some surveying as well among them regarding their likely changes that they would bring in place. And relative to therapy, for example, 1/3 of the agency respondents to our survey said they plan on no changes at all in the way they provide care to patients who have therapy needs. Another 1/3 of them indicated they weren't sure yet. They were still going to be looking at it, but they did seem to indicate a more patient-centered decision-making rather than business-centered approach. But 1/3 of the home health agencies also said they fully intend to reduce the number of therapy visits. So you could see two actions then, a reduction or a spreading out of the visits. We, are trying to deal with, achieving some consistency in home health operations. But the parties, that will be listening in on this webinar should recognize that not all home health agencies can be expected to make the same kind of changes or to behave the same way. So your participants in the BPCI innovation, should be, taking a look at who their partners are and what fits for their modality of caring for patients. We believe that great benefits have come to patients with the front loading of the therapy services, particularly with those joint replacement patients. And so we would hope the clinical gains that have come through that over the years would continue with the system But we also advise the home health agencies that, we're going to be watching, but we're their representative. The party they should be watching out for themselves would be Medicare and its oversight, because that change of behavior could lead to some kind of auditing of those home health agencies. From a pure numbers sense, those front-loaded patients are in the payment model as front-loaded care to patients. And so the reimbursement rate should reflect the front loading of those visits. So a behavior change around that, really is by and large unnecessary. What could drive behavior relative to the therapy, though, is that in this new model, when costing out the services, CMS gave a lower price to therapy services than they used to do it. So in reality, that 30-day payment for a front-loaded therapy patient will bring less revenue to the home health agency, which is why your constituency, Shawn, should be on guard for watching out for inappropriate changes within the home health agency. But the real guardrail there, home health agencies cannot do anything without a physician's order. So that's really where the controls will lie.
Perfect. And we'll, for our listeners here, we'll be touching in on the latter part of our slides with some of those prescriptive thoughts, such as Bill is saying, being specific with your orders. Thank you for those answers, Bill.
Yeah, so this next slide goes through a little more detail on the architecture of what PDGM looks like. The rules set out the payment rates, and those, in a proposed to final fashion, fluctuated quite a bit as everything was unfolding with this new model. In the end, there have been what I think most home health agencies would see improvements in the payment rates. The payment rate as a base payment rate for 30 days started out at just over $1,600, and now it's 17 and change. So, 18 and change. So it's quite a bit different. The revised behavioral adjustment, we'll talk about some more in detail how CMS calculated that. They continue an outlier component to this that's based upon an imputed cost. The costs are imputed based upon the volume of visits, but overall outlier patients within the Medicare home health benefit represent about 7 to 8% of the population, and they tend to be patients who have fairly predictable outlier needs, a patient who needs someone to provide an injection of insulin once or more a day. They've updated the wage index. The wage index applied in many provider sectors based on differences in wage on a geographic basis. They recalibrated all the case mix weights, and what we mean by case mix weights is that each of the 432 case mix categories has a certain score to it. It's a multiplier based on the payment rate. And then they modified something known as the RAP, the request for anticipated payment. And we'll talk in detail about that. It's a way of dealing with cash flow needs when a provider of home health has to wait somewhere in the neighborhoods of 45 to 60 days to actually get paid from the start of care. And then some paperwork requirements which will not affect anybody other than the home health agency on notifying the Medicare program when the patient's been admitted to service. So next slide, Shawn, thanks. We've talked about the 30-day payment unit and the dropping of the therapy utilization domain, but I just referenced the number of patient groups. In the old model that you were operating under in 2019, there were 153 different payment groups. It's now grown to 432, comparable to the DRG type concept of a patient classification system based upon certain characteristics. And the characteristics that matter to determine which of the groupings a patient goes depends on whether the episode is an early or late. And there's only one early, that's the start of care, 30-day period of time, and there has to be an interruption of time before you can get to another early one. A big measure within those patient characteristics that affects reimbursement is the admission source of the patient. Community admissions or institutional are the dividing line. Institutional meaning within 14 days of a hospital discharge or 14 days of a Medicare-covered SNF stay. That would then constitute an institutional admission. The differences in reimbursement between community-based admissions to home health and institutional admissions is very significant. More than half of all current episodes of care are community admissions, and those continue to grow as there is a shift to care in the community, utilizing home health services as a pre-acute or acute alternative to inpatient care. Now, the other two areas of measurement are focused mainly around 6 clinical groupings. There is a subgroup set within one of those groups. MMTA is Medication Management, Teaching, and Assessment. It represents about half of all of the clinical category patients within this new model, and it's subgrouped into these sets that look at someone who's got a cardiac condition, for example. And the second domain that's important is the functional level of the patient. The functional level of the patient is measured through the patient assessment known as OASIS, something which has been around a long time in the Medicare program. And I want to put those three things together for you here, the admission source, the clinical groupings, and the functional levels, to raise, kind of like, some questions about how strong a model this is in terms of its reliability to forecast costs. And a simple example I'll give you there. If you take a patient that fits into one of those 6 clinical groupings, one of those patients comes from the community, the other one comes from the institution, and they have an identical clinical status. They also have an identical functional status within this methodology that's employed here. So clinical and functional, the patients are identical. The only difference is one's coming from the community to home health and one's coming from an institution to home health. The difference in Medicare reimbursement within that 432 patient groups can range from $200 to $400, which obviously is material to the provider of services. What can the home health agency do about that? It's not like they could admit the patient to the hospital, so they don't really have control on it. But it may mean, because of the incentives, that you will see a shift of interest from home health agencies to try to get referrals from an institutional source rather than that. Medicare's response to why they did this is because their data analysis showed that patients discharged from a hospital, say, used more resources than the same type of clinical functional patient used when coming from the community. For some of us, that means that those other measures aren't particularly reliable, but this is what we have as a system model. Comorbidity adjustments are a new piece to this that matter. So you will find the home health agencies making sure they have all secondary diagnoses. The comorbidity adjustment is either a no adjustment, a low adjustment, or a high adjustment. It's no more precise than that, but it matters how many different comorbidities the individual has. I referenced the low utilization payment adjustment earlier, the acronym of LUPA. It's been around since the year 2000. In the pre-existing model, it was a 4-visit threshold over a 60-day period. Now it has a range that's specific to the 432 patient groups of 2 to 6 visits. Once you hit the threshold with LUPA, you would get, the home health agency would get the full 30-day payment. And so that is something that home health agencies will be trying to manage. They do not want to have a high volume of LUPAs because LUPAs almost by definition become losses for the home health agencies. Just the formula for calculating the LUPA amount was likely to bring a financial loss. What's continued from the old model is that all the disciplines of services are bundled into the payment, but what changes is non-routine medical supplies are also now bundled into that payment amount compared to the old model that had an add-on payment based on medical supply use. And just as the last note of the recalibration, home health agencies originally saw something in 2018, and CMS changed that around for the final 2020 version. So Shawn, next slide.
Yep. Bill, I wonder a couple questions on this slide that I'm sure our partners have. With the admission source, the community or institutional, would you please define what is included within the institutional? For example, inpatient rehab facilities, skilled nursing facilities, do those fall in the institutional category?
Yes, all of them do. The inpatient hospital, the inpatient rehab facility, the long-term care hospital, and the skilled nursing facility. The key thing is that the admission would have to be within 14 days of discharge of the last institutional setting. Now, if the person is residing in a nursing home, and it's well after any hospital discharge, and it's no longer a covered stay in the nursing home, it's not a Medicare covered SNF stay, that will not count towards an institutional categorization of the patient.
Okay, that makes sense with the skilled discharge. Second question on LUPA. It seems in the past it's been more of a hard code 4 and now 2 to 6. Where in the standardization of that are most of those 432 payment groups falling? At how many visits?
Most of them in a 30-day time frame rather than the 60-day time frame fit within the 3 to 4 range. There are a handful of those 432 that are up at 6, and a greater amount, but still not a dominant amount, at 2 visits. And there are some patients clinically that only need 2 visits. Most of the ones who end up with 2 visits in that 30 days are patients where some intervening event happened, either a rehospitalization or potentially the death of the patient. But most of them are in the 3 to 4 range.
Thank you for that. And just one other question. How substantially is a home health agency's reimbursement reduced if they fall into that LUPA versus the full 30-day payment?
Well, it depends upon the category within 432, but as the next slide will reveal, the base payment rate is $18.64, and with $18.64, the case mix adjustment on that could be as 60% of that or 160% of that. So there's a wide range that happens there. So let's assume that it's that they would otherwise get $18.64. If they get a reimbursement of 3 visits instead, that's likely to bring them $450. So a dramatic difference, right? So if the threshold is at 4 and they deliver 3 visits, they're going to get $450. If they deliver 4 visits, they might get $1,864. One visit can make that much of a difference.
Okay. And if I may ask you a question on this slide, so now that we have the 2 30-day periods, if an agency, let's take an orthopedic patient, were to have the therapy visits spread out over a 60-day period instead of the first 30, would the agency be able to bill that amount times 2, that $18.64?
Well, I mean, $18.64 is the base, and like I said, there's 432 patient groups. So there's a multiplier to the 1864 that could bring it down or bring it up depending upon which of those patient classifications fit for that particular patient. So what would the way this is set up, 1864, compares to a 28 and change for the 60-day period, but the multipliers have all changed. It should be ending up to be budget neutral in the aggregate, so it's a redistribution. So by moving it to 30 days, by moving into a second 30-day period, theoretically, it should end up giving the home health agency something reasonably close to what it would have received under the old model too. When I say reasonably close, it could be 10% higher or 10% lower, or it could be virtually identical. But nonetheless, you could see, the chief financial officer of a home health agency saying to the clinicians, can't you spread this out over another, into another 30-day payment period? So we know that the 99% of the home health agencies, the clinicians will guide, the clinical services rather than the CFO. But from a bottom line impact, it is an incentive to extend care.
Okay, thank you for that insight.
So as this slide portrays, we've kind of covered it all, 1864. Don't be too misled by the reference that CMS estimates that the average cost is 11%, lower than that. CMS's definition of costs is different than business definition of costs. are on this. For example, any taxes somebody pays are not included in cost there, and telehealth services that might accompany the disciplines going into the home are not considered a cost in all of that. Marketing is not considered a cost. So CMS, maybe it's playing a little politics on their policy side of it, but you know, that's what CMS portrayed in the regulation, so I wanted to outline it here. So next slide. You know, this goes into the behavioral adjustment and some of those what we call dials that Medicare is considering that the home health agencies might adjust in order to get higher reimbursement. The classification of the clinical group is the greatest one. The numbers in parenthetical setup, you know, really came from the proposed rule and the change to the final rule. Like 6.4% is what Medicare said it would be the potential level of change on clinical grouping. And what that means is, you know, you take all the ICD-10 codes and the code that you're supposed to use for primary diagnosis is the diagnosis that is the reason why a person's receiving home health services. Sometimes it's the same as the discharge diagnosis from the hospital, but not all of the time is it such. So the home health agencies had been putting primary diagnosis on the claims over the past years, but it didn't affect reimbursement, so it wasn't subject to any kind of review or audit or even much concern. And CMS built this payment model based upon that database. At the same time, CMS looked deeper into the information and said there are going to be circumstances where a different diagnosis is likely to come about as the primary reported diagnosis in the new model because it now matters. And it particularly matters, obviously, if it brings up reimbursement. So when looking at a behavior change on clinical grouping, it's a combination of two things. One is greater degree of accuracy in setting out the primary diagnosis, as well as a risk that some providers, when given a choice between one code and another, just choose the one that pays a higher amount of reimbursement. Comorbidities is all about just including the data there, and the LUPA reference of just under 2% is CMS's projection of the frequency with which agencies would add visits to get over the LUPA threshold and the corresponding effect on spending of just under 2%. So that would mean they don't expect 2% of the cases to go up from LUPA to full reimbursement, but more of a 1.88% impact on spending. That added up to 8.389%, an increase from the proposed level. But what CMS ended up doing, and this was to their credit, I guess maybe to their credit and our advocacy, we tried to get them to understand that you couldn't expect 100% of behavioral change starting on day one for 100% of all home health agencies with 100% of their patients. So they recalculated and said their projected adjustment was 4.36%, about half of the otherwise the full amount. What that meant was that CMS took the base payment rate that otherwise would be set and reduced it by 4.36% to account for this risk of behavioral change to try to end up budget neutral. It sounds confusing, sounds technical, absolutely is, but you know, it was important to the home health agencies not to start off with an 8.389% cut that we felt would send a message to the agencies. You better make these changes or you're going to be nearly 10% in the hole financially. We're still concerned that with the 4.36, it's triggering behavior change rather than reflecting what actually otherwise would occur. Other sectors have had these adjustments as well, like hospitals, was the most recent one. Most of the time what Medicare does is they bring in an adjustment after behavior has changed, and there's that evidence out there to be able to calculate it. With the Bipartisan Budget Act, Congress said, CMS, this is your job now to kind of forecast what it would be. We hope their forecast is a little better than the weatherman's forecast.
Sorry to interrupt there, Bill. A quick question on this slide. You mentioned guardrails for behavioral on the previous couple slides ago. Is there an adjustment to an agency's reimbursement if they don't fall within these frameworks?
No, this framework is a global one. You know, looking at the entire home health community on all of the patients served. The primary guardrail is that CMS is required to continue to look at actual changes in behavior and the impact on budget neutrality. So if they overstate what the anticipated behavior is, say for example this 4.36 is really only 2 points, then Medicare is required to account for their overstatement by increasing payment rates in the future to make up the losses that they put on the backs of the home health agencies. Likewise, if they understate it, to increase that adjustment in future years.
Okay. Well, thank you for that, Bill.
Yeah, but important to note what you brought out. This is not based on individual agencies. It's the global side of it. So this next slide, focuses in on a subsection of home health agencies that operate in rural areas. For decades, there has been a payment rate adjustment for home health agencies that operate in rural areas under both evidence and sometimes just theory that the cost of care in rural areas is greater to provide home health services. I mean, the logic is there. A home health agency could drive 30 or 40 or 50 miles to get from one home to the next to deliver services in a rural area, and you have a lot of then non-service time while that professional is transporting from one patient to the other. Other costs of rural care demonstrate that there is a higher incidence of services delivered in a lot of the rural areas because of the lack of other healthcare resources. There had been for a number of years a 3% add-on to home health agencies that served patients in rural areas. It was based on the location of the patient, not the location of the agency. And then in the Bipartisan Budget Act of 2018, Congress modified the rural add-on to distinguish between whether the patient is in what's known as a low population density area, defined as a county with 6 or fewer people per square mile. We kind of labeled it ourselves a frontier area. And they raised the add-on last year from 3 to 4%, but they phase it out over a 4-year period by 1 point reduction each year. The second category of high utilization counties is where those counties have a higher than average utilization of services in terms of the proportion of patients and the volume of care those patients get. That add-on was reduced, cut in half starting in 2019. 2020, it is only a 0.5 point differential. The theory behind that is one we contest, which is that because they're in a high utilization county, there's no reason to incentivize services to the home health agencies. What's really odd is you have quite a few agencies that are in the low population density area that are also high utilization counties. And so we don't think the theory holds water. More likely, the reason why it's high utilization is that the alternative availability of services is significantly less than you would find in other parts of the country. Nonetheless, this is what we're living with at the moment, a reduction of the add-on in those counties and a phasing out. Those counties tend to be in Texas, Oklahoma, and Florida, rather than the Midwest and certainly not the upper Northwest or anything. And then there's everybody else, which is about 85, 90% of all the other areas. The 3% add-on, was there in 2019. It's now reduced to 2% and 1%. What that could trigger, it is an issue of access to care in rural areas. The rural home health agencies as a group tend to have not just higher costs, but lower margins. And so managing to the penny means that if you cut a point or 2 points or now 3 points from their reimbursement rate from Medicare, you could be financially destabilizing the agency. So it's it's an issue of advocacy for us. But from your side of it, I think, Shawn, your constituency has to look to find out how stable the home health agencies might be.
Yeah, I'm really glad you mentioned that last part. And on our analysis in a few slides, we want to highlight that really to be watchful for our partners in those rural areas, given this reduction of 3 points. As a former business owner myself, I can just imagine, the loss of 3 points can significantly, on my revenue, can significantly affect my bottom line. And those rural areas are so expensive to serve. So we will have an analysis slide here in a moment on that. Thank you for that, Bill.
Yeah, and the last few slides I'm going to get through quickly because they're just FYI quick things. As I mentioned, the outlier system continues. They changed it a little bit, so there may be a decrease in volume of outlier claims, but I don't think that's a really big worry for anybody. The next slide on the RAP phase out, something to be aware of. The home health agencies had been getting 60% of the anticipated payment that they would ultimately receive for a 60-day episode of care, but they will only be getting 20% of what's anticipated for the 30-day period of care. So the key thing for the home health agencies is to find a way to have the capital in order to meet payroll in the interim, because you can anticipate that in a 30-day period of care, by the time they get the paperwork together, submit the claim to the Medicare program, pass through the 14-day floor, and after receiving the claim, you can be looking at 60 days from the start of care. So agencies need the financial capabilities to meet payroll and other costs in the interim. This is going to create some cash flow problems for the agencies. Something in terms of your relationship with agencies to make sure you're dealing with somebody who has that ability so that the doors don't close overnight.
We see this as a very key factor for the cash flow, as you mentioned, of the agencies, and something that we need to vigilantly monitor in our partners to make sure, as you said, that they have the means financially.
And the kind of analysis done by some of our financial experts are the key months are going to be likely March and April. Because we've got the old system phasing out and those claims are being paid, so that helps on the cash flow, and they've got their wraps, as we call it, there. But March and April is when we might start seeing some things. This is really a short-term issue for most of the companies, so if they make it past April, they're probably in good shape on this. And what takes is, some of the adjustments that's going to be there that affect third parties. The home health agencies will be going to the physicians earlier and more frequently to get the documentation necessary to support the claim, the certification signed, the orders signed, the change order signed, in order to have, a more timely claim submission schedule, so that they don't have a long period of time between the start of the care and the reimbursement receipt.
This is key insight. Thank you, Bill.
And the next two slides, just an FYI, these are kind of a summary of what we've gone through here, so we don't need to read those to you. And my final slide before Shawn, takes the reins on this, from a conclusion standpoint, this is affecting both patients and business interests, and not just first-person businesses like the home health agencies. It will have impact upstream and downstream. We have really felt that the best thing an agency can do, but it's not fully within their control, and that's a balanced patient mix. Because what's happening here is a bit of a redistribution. The most profitable of patients, for lack of a better label, were therapy patients. That's not going to be the case in this new model. Instead, the redistribution shifts higher reimbursement to wound care patients as an example of one group. Key factor, and we're working with the Medicare program to get this word out there all over the place. The Medicare home health benefit itself has not changed. It still provides for unlimited episodes of reimbursement. The same disciplines are covered for services. There's still no copayment for the patient. The key remains the patient has to be homebound and in need of skilled care. So what's really been important, we think we've got this fairly well happening across the industry, is a thoughtful transformation, trying to avoid knee-jerk reaction. When you've got 11,000 home health agencies out there, you can't be assured that everybody has the same culture and everybody has the same approach. So Shawn, that covers what I intended to cover today, and I know you want to get into some more detail, and we can have some further discussion. So it's all yours.
Thank you so much for your insight, Bill. One quick question on this slide. You you mentioned earlier about the therapy having a decrease in its portion of reimbursement. Some of those clinical diagnoses of the groupers of the 432 becoming more profitable. Will it nonetheless behoove and benefit an agency to continue to care for those, say, orthopedic rehabilitation patients?
We absolutely think so, and that if there is a knee-jerk reaction to the reimbursement rate change leading to home health agencies reluctant to provide therapy services or trying to provide less, what we've explained to the agencies are there are other factors at play that could make that approach penny wise and pound foolish. For example, there are 9 states in a value-based purchasing demonstration program where as much as 8% of their payments are at risk if they fall into the bottom half of performers. It goes all the way up to 8%, so you got to really be at the bottom, but 8% is a huge amount there, and that's based upon patient outcomes, a whole series of measures that go in there. So they could be hurting themselves financially in a direct way in those value-based purchasing states. Beyond that, though, there is publicly available data in 2 forms, Home Healthcare Compare, as well as the star rating system. And it is increasingly happening that referral sources and Medicare Advantage plans in terms of selecting network participants are looking at those measures. And so if therapy services are reduced, leading to a reduction in the quality of patient outcomes, home health agencies could find themselves out of the mix in terms of receiving referrals, be they from hospital discharge planners, physicians, or becoming part of a network with the managed care plans. So we're trying to get the message across there. But that there's one other thing which is not as much a direct thing, but maybe the scariest one, and that being CMS is already prepared to evaluate changes in the delivery of therapy services comparing 2017 to 2020. The same patient assessment process was in place, so they are well positioned to be able to say, okay, if you provided more services in 2017 than you are in 2020 for these therapy patients, were you overutilizing services in 2017? And if so, we're going to audit you and take money back. Or are you underutilizing services in 2020, in which case we may terminate you from the Medicare program for violating clinical standards of practice. So we're trying to get the message out there for home health agencies on the therapy side in particular, not to overreact. Our concerns are raised by what we've seen in the nursing homes with their change to the PDGM model in October.
Well, that is great insight, and it seems logical from just a business standpoint that though there is less reimbursement on the therapy for those rehab patients, that would still be a major portion of revenue that a home health agency would want to capture. The revenue is additive, the revenue is covering the costs, so it doesn't seem logical that we would see a significant shift away from home health agencies wanting to admit an orthopedic rehabilitation patient. And as you said, all those guardrails are in place. Bill, I'd like to do just a quick time check. We have these slides, as you know, coming up from the Fusion 5 assessment purpose that we have built with your insight and input. I can do that in a separate webinar, or we can continue, say, for another 15 minutes. What does your schedule look like?
I'm open to continuing this, so, because I think, we could have also a discussion as your slides come up.
Okay, thank you very much, Bill, for your time. So I'll be transitioning into what a BPCI-A Episode Initiator, Advanced Episode Initiator needs to know, and we'll be adding Bill's insight to these slides. So as you know, home health is still a key to our success. It is our least expensive next site of care. If we can have somebody have the support that they need to be in the home environment, not have a, say, skilled nursing facility admission for other than a skilled need, then that is our best case scenario. I've been a nursing home administrator for 21 years, and I can tell you about nosocomial infections and airborne pathogens and just the infectious nature of an institutional care. So certainly if we can have somebody heal at home, that's the best place for the patient. and we want to make sure that they have all the support they need. Home health is such a key partner for a BPCI-A Episode Initiator. I wanted to add this CMS slide. I'm a visual learner, and I think this can help from many of our groups. That, as Bill was talking about in his slides, there are these different components that go into the new reimbursement system. The admission source, whether that's coming from institutional or community, the institutionals including the LTAC, IRF, SNF, those carry a higher weight, as Bill was saying, of reimbursement. The clinical groupings, which have now expanded, as Bill was saying, the functional impairment level, I really like that Medicare has gone this way and really reflecting the comorbidity and the needs of the patient. And those work in tandem there on the bottom too. So we have a few slides on what stays the same, what changes. This is still that a patient needs to be homebound. It is still a prospective payment system. The home health agencies will still be using their assessment instrument, the OASIS. The scope of benefits, as Bill was saying, is the same. Any number of therapy visits can be provided. And one thing I want to highlight is that our home health performance network guidelines stay the same. So we still want our agency partners to be visiting patients within 24 hours, to be having that Friday night tuck-in call, making sure that they're good for the weekend, having the 24/7 availability to be contacted. So at its core, this is not a departure from the home health clinical and therapy visits. Some things that do change that Bill has covered, that the request for anticipated payment now changes to a 20/80. So where an agency used to be getting 60% of that anticipated payment up front, now they would only get 20. And there is some titration there through 221, depending if an agency is new or existing. But that is a big difference to cash flow. And that's great insight that Bill provided, that we really want to start looking for that about March and April. We need to be having these proactive conversations now with our agency partners, if they are ready. And I'm sure they are. We work with the best agencies, but we need to be having these conversations. There are two payments or resources, those RAPs that are submitted. So it is more work for the agencies. It is noteworthy that some of the ICD-10 codes that were more general in nature will be rejected under PDGM. So the agencies will definitely need more specific documentation from our physician providers. The LUPA thresholds, as Bill mentioned, is now a range that varies depending on one of those 432 groupers, not the hard code 4 as it was before. And then the higher rates that Bill mentioned, institutional versus community, and all of those elements now coming together to make the payment. Bill mentioned the CMS guardrails of monitoring to assure that therapy utilization remains consistent with the past, and that there would not be a significant elevation in secondary diagnoses. And remarkably too, these therapy visit thresholds are prohibited. And this was in the actual act itself of Congress. So no longer will we have the experience of, does the number of therapy visits get to a certain threshold? It would more just be that 30-day payment. Bill, any comments on this slide?
No, I think you've covered it well. I mean, okay. It does indicate there's change, and everybody needs to participate in watching what happens.
Okay, thank you. The insight here on analysis is that some home health agencies will be adversely affected. One thing I've learned from Bill and the generous time that he's given me is there are some draconian speakers out there who have made some estimates of how many would fail. But we need to bear in mind that this is a budget neutral program, and that there will be those that do well and that are able to have good cash flow and get their payment systems going efficiently, that will survive and likely even maybe thrive in this system. So Really, it's just going to be a county by county analysis of our partners. And so I went into this with the hypothesis that this could be many groups that would fail. And I've come out from my working with Bill to understand that it really is just going to be very specific to each individual agencies. We've talked about the cash flow issue, something to look at there with RAPs being phased out, and general diagnoses not being covered. We've talked about the rural add-on factor of geography, and we've talked about this last element too, that PDGM takes a more functional view of the patient. So something that may happen, home health could likely want to diversify their revenues, taking on these or other type of programs. Certainly wound care could be an increased focus with some of the adjustments that have been made. Agencies may want to take on non-medical caregiving services, do some staffing agency work. And to the extent they do, I think this inures to our benefit favorably. The more continuum of services the provider has, the better for us. In our last couple of slides here, we have a table, and this will be made available to you by handout, that summarizes these factors that we've talked about. There are now 432, or just a broader range of clinical groupers, a very holistic view of the patient in terms of functional impairment and comorbidity adjustments. We see these as good things. The admission source and timing, meaning where is the patient being admitted to home health from? Is the order coming from the institution or from the community? That doesn't really affect us in that the BPCI-A episodes are triggered by the anchor hospitalization. So this will be not applicable to us in our opinion. The therapy utilization and timing of visits is something that we should be watchful for. It's a little bit lesser of a rate for therapy, and so we just want to make sure that they're still receiving your orders. If you are ordering therapy times 2 to 3 a week for 2 to 3 weeks, that's the order that the agency will follow. So be specific with your orders as to the outcome or the number of visits that you feel are best, and certainly then we ask our partners to be communicating constantly back with you of what they're seeing with the patient and if they need more visits. The timing of the visits, there is that fact that there are 2 30-day billing periods here, but as Bill mentioned, that likely wouldn't be too much of an impact. We are concerned about the phase out of RAPs, that could delay, that will delay cash flow for our partners. The rural add-on factor is very remarkable for us. We need to assure that our network providers are going to be able to continue to serve our rural counties. Bill, what thoughts do you have what insights on this slide?
On this slide, two things stand out for me, and that is, the admission source and timing. You may find with this new model that you have greater access to services than before because the home health agencies would love to cater to discharges from the hospitals given the reimbursement model. The second one is that item 4 on therapy utilization and timing. Maybe this is repeating what I'd said earlier, but home health agencies do not decide how many therapy visits are necessary in the end on their own. It's not a unilateral authority that they have. They can only deliver the care based upon a physician's plan of care and an order from the physician. So partnering with the home health agencies to figure out the best course of action clinically for the patient is important, with the knowledge that, the home health agencies have different reimbursement effect based on the volume of days of service now rather than the volume of therapy services. So that front loading, may be something that gets into the discussion, but ultimately in the end, the home health agency is not the one that decides whether they're front loaded. It's the physician that does.
That's a key point. Thank you very much for those insights. Something we've done is weight these variables, the benefit on the X and then our ability to mitigate that really negligible in both, but the benefit for us of broader clinical groupers, functional impairments, the more holistic nature of the assessment are all good things. We are watching and we need to be watchful and concerned about those elements that we talked about, making sure that the therapy visits are as you've ordered, that nothing is going to change, and that those are front-loaded if that's your desire as the surgeon. We need to be watchful of this rural add-on being phased out or reduced and making sure that our partners can serve those areas. And then we need to be asking the hard questions to our partners of how prepared they are with this new model. So the things we can do is be a good partner. Bill was indicating that the agencies would likely be coming to us for more documentation so that they can capture the comorbidities, so that they have a strong primary diagnosis. Anything that we can proactively send our partners to fulfill their needs for documentation is what we should be doing. And if they need records or certainly the certs signed, that's something that we should be willing to do. Bill, I want to ask you a question on this. I know some of our surgeons sometimes hesitate to sign or to be involved with the care of the patient ongoing, signing the care plan, but yet will sign the cert. Would you please dive into that a bit, the difference of cert and care plan signing?
Yeah, the cert is a statement that the individual's needs for care represent the level of service required to qualify for Medicare home health benefit. The typical situation for a surgeon is the patient is handed off to a physician in the community. An attending physician might be a label that could be used, and ultimately that physician is likely to be the one that ends up ordering all of the care, change orders of care, and signing off on the plan of care. It is absolutely acceptable for the hospital physician who's discharging the patient from inpatient setting to put together the starting point of a plan of care and order initial services as well as certify the eligibility. But it's also equally okay for the physician to hand off the patient to a community physician who might even be ending up doing the certification. So what you'll find so often is the physician in the hospital is the one who is responsible for the face-to-face requirement, and then the community physician responsible for everything else thereafter. So there are options on how it can go, and we don't see a change in that coming from this particular model, though.
I appreciate that insight. So we will need to continually monitor our performance network partners as we regularly do. This model does adjust their cash flow, so we'll be needing to ask those questions. And our performance network guidelines remain the same, seeing patients within 24 hours, giving us weekly progress notes, et cetera. So we want to be as good of a partner as we can for our home health agencies. I would add in here LUPA. We don't want to put our partners in a situation where they're going to be coming up against that low utilization. It's going to vary, as Bill said, for these 432 groupers, but most of them being 3 to 4 visits. I believe that home health is our key partner in the continuum, together with the outpatient therapy providers. So bear that in mind as you're developing your guidelines. I know some of our partners have different levels of therapy visits, and we want to be keeping our partners whole and maximizing our partners, which really can serve our continuum and our interests the best.
Yeah, if I could offer follow,
please.
Shawn, if I could just offer the following on that, given that this is when a BPCI-A model, that if there is an underutilization, in retrospect, an underutilization of services, in 1 out of 10 cases, you might find that person goes back into the hospital. That wipes out any potential value from the underutilization very, very quickly. So this is where the partnering really plays a big part in successful bundled management of these patients.
That's such a great point. Thank you very much, Bill. And with our 90-day interest in the patient, that's the last thing we want is a readmission. Great point. We have a few questions here that I've developed. You know, we should ask our partners. Do you anticipate lowering your number of therapy visits for some cases in PDGM, such as orthopedic cases? Now, these really are rhetorical questions, but they are pointed and open with professional candor for that very purpose. Are you prepared financially and operationally to succeed in PDGM? Just a few ideas in your mind. You don't need to ask this, but RAPs being phased out, these general and less specific ICD-10 codes being rejected, the takeaway of the rural add-on, those naturally are going to affect the finances and the operations of some of our partners. And then the rural factor that we've talked about. Will you be sustaining operations in those rural areas that you serve? We have, if you would, as far as questions, direct those either to your regional clinical director or your regional director of partner services, and they can field those to me, or feel free to email me directly. When you do, just if you would, CC in your regional directors, or if you just send me the email, I will CC them in as well. And Bill very kindly has offered to answer any questions that we are not able to answer, so we can field those. I just want to thank again Bill Dombi. It's really a privilege for us to be able to have the president of the National Association for Home Care, the largest home care association and advocacy group in the country, joining us. So Bill, your insight, your experience is just quite significant, and it's really a privilege for us to have been able to spend this time with you. I just want to thank you again for your time and your insight.
Well, thank you, Shawn, for the opportunity, and I wish you and all your constituents the best on this, and if there's anything we can do to help you further in the future, we'll be there with you.
All right. Thank you so much, Bill.